Hey, welcome to Health Equity Mondays, hosted by Jasmine Leonard
and Omari Richins. Here we'll talk about all things health equity, public health, and culture.
Let's do our part to move health equity forward and all that jazz. Hello, Happy New Year. Welcome everybody to the second season of Health Equity Mondays. This is our January episode, and you are joined by Jasmine and Omari, and today we are going to discuss medical debt and the health equity of medical tourism.
Happy New Year, everyone. It's awesome to be here with you all. Welcome to Season 2, Episode 1. Going to be unlocking a lot of different health equity insights, very, very intersectional with public health. But glad to be here and looking forward to sharing more information with you.
Yes. So how have you been? We're in a brand new year. What's been going on?
I feel like it's been a while since we did this. But it's almost the end of the month, which is crazy. So New Year, things have been going well. I feel like this first month has been a lot of just trying to get back a handle of everything because I was out of work until I was on PTO until January 8th or something like that. So I just came back and there was a lot of work stuff to do, then a lot of public health millennial stuff, and then a lot of people emailing me, and email is probably my least fun thing to do, but it has to be done. But we are making good forward momentum. I cannot complain. Work is going well. Public health millennial is going well. Brothers in public health is going well. Go follow all of those if you haven't noticed yet.
Just list them off. I mean, how many are there now?
Just those three hats. That's those three. It's interesting because that's how I have to be in conversations. I have these three hats, and then I lay it out. So it's like trying to get very succinct.
Okay.
Yeah.
Got it. Okay.
What's been going on with you?
I have been enjoying the new year. I made my vision board. I picked my word for the year. I am just tapping into all the manifesting that I can do for the year. Back in school, thankfully only taking one course this term, so it's very light right now. I'm enjoying it. It was kind of a nice little creep back into school before the nonsense of fourth term. And yeah, it's been a good year. I've been feeling pretty committed to some goals that I made and just wanting to be a healthier version of myself. Not like I didn't do the, oh, I'm going to lose whatever X number of pounds or whatever, but just wanting to be a healthier version of myself mentally, physically, emotionally, and all of that. So it's been good.
Well, I love that for you. And the people are begging to know, what is your word for the year?
My word for the year is opulence.
All right, you gotta define that for us out here.
So opulence is like decadence, extravagance,
okay,
vast beauty, things like that. So really just taking, the normal kind of abundance idea and multiplying that by 100, just wanting it all.
I'm selling you all those manifestation vibes, and I hope that your 2024 is very opulent.
Thank you.
You're welcome. We're learning things here today. And before we hop into our first topic today, be sure you hit that subscribe button so you can stay up to date with Health Equity Mondays and everything, public health careers and the public health millennial, and share with a friend who will get some value from this episode. So our first topic today is around medical debt. The US consumers have $88 billion in medical debt. That's 23% of the population. 62% of bankruptcies in the US are related to medical debt. Households without full health insurance are nearly twice as likely to have medical debt. Why is medical debt bad? It affects someone's life through being reported on their credit, which can lead to them being denied housing, denied the ability to rent, locked out of employment prospects, locked out of lower insurance rates, and can lead to a vicious cycle in someone's life. In a recent survey, 44% of Americans can't afford a $1,000 emergency expense. 1 in 5 Americans have no savings at all. 72% of people report that their medical debt was caused by a one-time bill or short-term medical expense. This is to say, someone could be trying to get by and get sick, as we all inevitably do, and they have to seek care. Depending on what services they require, their insurance status, the hospital they go to, can result in varied hospital bills. 56% of adults with current healthcare debt say they owe less than $2,500. 16% say they owe less than $500. 18% say they owe between $500 and $1,000. This is to say that the medical expenses does not have to be anything greater than $1,000 to cause a large population of Americans into medical debt, which, as we shared earlier, can sometimes impact employment prospects. And in fact, there's data to show that healthcare debt is mostly due to acute medical expenses. This is also a reason that people forego accessing healthcare. 8 in 10 adults with healthcare debt report skipping or delaying care or medications due to cost. But you may be asking yourself, okay, this is Health Equity Mondays. We talk about health equity things, racial equity. So where is the intersection between medical debt and Blackness? And this is where we get to Black households have the highest rates of medical debt, followed by Hispanic households, then white households, and Asian households. And the rate for medical debt for Black households is 28%, and it's 17% for white households. So why is this the way it is? Historically, Jim Crow segregation in healthcare, where the entire country was segregated, Blacks in the North got substandard care, and we all know Black folks in the South probably didn't have any hospital or medical services available to them. This has carried over into today's world with low insurance rates for many Black adults. Many Southern states have not expanded Medicaid. Despite the uninsurance rate hitting an all-time low of 7.7% in 2023, there are still places with populations with high uninsurance rates. Additionally, Black Americans are more likely to work a low-income job and a job that does not provide medical benefits. Black adults are more likely to be contacted by collection agencies for medical debt. About half of Black adults with healthcare debt say their credit score was negatively impacted by debt. And a couple stories on that is, my credit score is so low, I can't get financing for a vehicle, causing me to lose my job due to lack of transportation. This was a 31-year-old woman with $5,000 to $10,000 in medical debt in Arkansas. And another quote was, said goodbye to any positive credit scores, meaning that since all my medical bills went to collections, I've lost over 250 points on my credit score and could no longer be even considered for any loans. 38-year-old man with $1,000 to $2,500 in medical debt in Iowa. 1 in 7 adults with healthcare debt say that they have been denied care by a medical provider due to their debt. And there's also a disparity here where the percentage of Black adults is 22% compared to 14% for Hispanic and 14% for white adults. There are many underlying issues that need to be dealt with, such as Medicaid expansion, decreasing uninsurance rates across the US, and expansion of charity care policies by state. While medical debt is a huge problem and affects so many Americans today, there are clear racial disparities that need to be addressed so that we can all achieve health equity. And late last year, the Consumer Financial Protection Bureau embarked on a process to remake the rules about what kinds of medical debt can show up on an individual's credit report. So if this legislature is passed, there's going to be a lot of opportunity for medical debt not to be reported on someone's credit report, which can positively impact their lives in so many different ways. So this is a great step, and potentially this is a great step, and I hope that this legislature and policies are passed throughout the country.
I normally am not surprised by things, but I think I'm surprised by the fact that you said that medical providers refuse to provide care to people who have medical debt. Because my question is, how do they know? And are you serious?
Right.
Like,
right. It begs the question of the system, and I'm not too sure how they do figure out that information, but I'm guessing that they could probably figure it out pretty easily once you get into their system, I would imagine.
Right. So I guess if you're going to the same hospital or going to the same system and then you potentially don't pay a bill or something like that, I could see that.
Maybe it is, even if they come in for like an initial first assessment and then they get whatever information they need and then they're able to see the person's files. I don't know. I'm completely ignorant to how this works.
Yeah, this is not something that I think gets enough highlight in the conversation. I mean, I think that a while ago there was a large conversation around medical debt, but then you only heard these like large stories where people were like they have cancer or they're in a car accident or something like that. But to know that the majority of it is small, kind of, oh, I potentially had the flu and went to the hospital, like that's something that I feel like should be talked about more.
I agree with that because the narrative is that it's going to be like $100,000 bill for something, but the reality is that it's going to be $100 or like a couple hundreds of dollars to thousands of dollars, and people just don't have that to pay it off. But to your point of how horrendous it is that people are getting denied health care because of that is crazy, and that should not be part of the American system when there's like so much funding and money that's aside for health care in this country. So yep, here we are, but glad to be talking a little bit about this topic today.
Yes, and I think it's a perfect tie-in to medical tourism because when you think about it, the reason that a lot of people are in debt is because things in America cost so much in terms of medicine. But you can go to other countries where it costs less and where there's potentially different levels of access. So before I get into what medical tourism is, let's take a break and shout out all the things that we have going on right now.
The only thing that I want you all to do right now is to subscribe for early access for the community that I'm creating. It's really going to be a space where you can have new public health friends, be a part of a public health community online, gain skills and knowledge, feel more confident, have a sustainable career, have meaningful discussions, and share insights, resources, and collaboration. So I look forward to having you all join. If you join the early access waitlist, you will get access to a discount of more than 30% on the monthly subscription for the community. So be sure to join today, and I look forward to having you be a part of the community.
Yes, the community is going to be so much fun. I'm excited for it. I'm just asking people to follow me on Instagram right now. I thought I would be back with my newsletter, but still on hiatus. Life has been lifing, but when it's back, I will be asking you all to subscribe.
So now tell us more about medical tourism.
Yes. Okay. So medical tourism involves any time a patient intentionally leaves their home country to access non-emergency healthcare services abroad. So it has been gaining popularity as medical tourists seek to access care motivated by health service issues such as high costs, lengthy wait times, and or a lack of accessibility in their home systems. Today, the market of medical tourism is valued at hundreds of billions of dollars, United States dollars, and is constantly rising, thus presenting a multi-way matter of subject. In some countries, the health systems are losing patients because of high prices, which makes the patients go to other nearby countries. And in some cases, insurance systems do not allow patients to use any non conventional approaches in their therapies and healing processes, making it attractive to go to other countries for healthcare. So you're probably like, why does this matter? And why are we talking about this? So there's not much known about the true impact of medical tourism on departure or destination countries. Some articles state that medical tourism is a source of inequity, while others state that it is a potential cure for inequity. So, a 2010 scoping review found 5 cross cutting themes when researching the literature to determine the impact of medical tourism. These themes framed medical tourism as a user of public resources, a solution to problems, a revenue generating industry, a standard of care, and a source of inequity. So if we focus in on medical tourism as a source of inequity, the scoping review found that medical tourism has been charged with exacerbating health inequities in lower and middle income countries due to brain drain. So brain drain is the idea that healthcare providers and those responsible for advancing technology are lured away from their home countries or cities to work in more resource or higher paying areas. Because medical tourism facilities are primarily urban, this process also increases the internal migration of healthcare providers from rural areas into cities, thereby enhancing rural deprivation. Additionally, medical tourism can lead to locals being priced out of their own healthcare system, as demand from foreign patients can drive up the costs of providing care for everyone. The financial gains medical tourism offers lower and middle income countries has worked to shift healthcare investments into expansive, high technology tertiary care that benefits a limited number of patients for the high costs. This is especially inequitable given the large proportion of the population across lower and middle income countries for whom basic medical services are prohibitively expensive or simply unavailable. Additional inequity happens when medical tourists traveling from lower and middle income countries may end up exhausting their finances to access care, impoverishing themselves and their families, and thereby creating or exacerbating inequities. When patients from countries with strong publicly funded healthcare systems engage in medical tourism, they undermine the ethos that has allowed these very systems to develop and survive. They do this by effectively introducing a second tier of care available only to those with the ability to pay, an option that runs contrary to the provision of exclusively publicly funded healthcare. Their actions extend further than the appearance of inequity, as each medical tourist puts his or her support behind the private provision of healthcare and a conception of healthcare as a commodity. This also applies to countries lacking in public health care, as the affordability of medical tourism works to neutralize pressure for reform and the equitable distribution of resources. On the other end, when talking about medical tourism as a potential cure for inequity, articles said that there was the potential for medical tourism to allow lower and middle income countries to become more competitive with countries that are a higher income. So the idea being that here you are in countries like the Dominican Republic, Costa Rica, and other places that are now being thought of as equal or higher to the United States and Canada because people are wanting to get services there. So there's lots of conversation on both ends, but I thought that this was really interesting to bring up, as I actually am going to be someone that is embarking on medical tourism in a couple of months. So this was near and dear to me, and I wanted to bring it to the table.
Thank you for sharing. I think it's an interesting topic, and it hits on a lot of different intersections of things going on. I think about brain drain. I think about like being from Trinidad and a lot of doctors wanting to become doctors and then like move abroad, come to the US and practice medicine, and how that affects the Trinidad ecosystem. I think about very similarly in Cuba. They have like one of the best medical training systems in the world. And a lot of those doctors also get exported to other places, and what that has done for Cuba. And then I guess you gotta think about like the reels where the people from the BBLs and they have to sit on their special seats in the planes coming back from like Brazil or Dominican Republic. And then the last kind of thing that comes to my mind, and I guess this is like not thinking about low to middle income countries, but thinking about people who are like digital nomads and a lot of people who travel or do that kind of travel, and just how cheap or a lot cheaper it is than US health insurance can be, just having travel insurance and the benefit that has. But I haven't really thought about it from the other perspective of lower to middle income countries and what that means for them. So yeah, very, very interesting, and definitely a topic that is not, I feel like, not spoken about enough as well in like a broad brush, if that makes sense.
Yeah, it's definitely something that I think could benefit from more discussion, especially, I mean, not everyone is going to other countries to get a BBL. Guys, I'm not going to get a BBL. There are other reasons to go to other countries.
Right.
I've seen a lot of people go for like just oral healthcare, because when you think about it, our healthcare system in terms of dentistry and everything like that is usually a separate insurance, and it's very costly here when you have an issue. And then you have to think about how much are you saving by getting dental insurance here versus being able to go and get orthodontics and stuff in another country. Lots of different ways to think about medical tourism. And something that I definitely am keeping on the topic list to see if we get more information about the health inequities.
Yeah, that makes a lot of sense. It isn't just this one thing that we have in our mind. It can look a lot of different ways, and many times, like some drugs aren't allowed in certain countries, or they're more expensive in the U.S. per se, and people have to go to different means to get the access to the care that they need for themselves or their families. So, yep, a lot in there, and I think it just talks about like it brings up the question of what does globalization look like, and what does globalization look like for public health, for healthcare, for health insurance, and how does that work towards equity, or how is it creating more inequities? And I feel like it's open for debate, but
Yeah.
not for right now with you and I though. Maybe you can send us an email.
Yes, and if you're living in another country listening and you have some thoughts on it, I would love to hear that, because I think, why not?
Sounds good.
Yeah. Well, whew, it is time for equity in action. Now, we still haven't thought about what I win from getting more right last year.
We'll figure that out for February.
But
we promise. If you have ideas, you can email us as well.
yes, please do, because my brain is not really thinking on all cylinders to be able to figure out what I should win or what Omari should lose. So it is time for Equity in Action. If you're new, Equity in Action is our true or false game in which we try and stump each other about health equity questions and just questions of healthcare, public health, anything really. So if you have suggestions for an Equity in Action quiz one day, please feel free to email us or, DM us. You know how to get in contact with us. But it is my turn to stump Omari.
Wait.
Are you ready?
Been waiting.
Been waiting.
Yes.
All right. Okay. For a hip replacement, the average waiting time in Denmark, Hungary, Italy, and Poland is higher than that of the United States.
The average waiting time is longer in Denmark, Hungary, Poland, and somewhere else.
Yeah, Italy.
So you're saying it true or false if it is longer in those places?
Yes.
For a hip replacement?
Yes.
That's tough. The first thing that I think of is like, because I thought you were going to say Canada, and then I was going to be like, oh, it's absolutely longer in Canada. but you didn't say Canada. But I feel like in these quote unquote like more socialist countries that have more supports for their peoples, though they may have like more access to healthcare, they mightn't have the same speed of access to healthcare as in the US, which is like for example, what happens in Canada. It's like you have access to healthcare, but depending on what you need, there might be a long gap in getting that care. And I'm like, my sister who lives in Canada is like all too familiar with that. So I'm gonna say that it is, yes, it is longer.
So you're saying yes, it's longer.
True.
And you are correct.
Okay.
So the average in those other countries is about 180 days, and here in the US, it's about 5 months.
Oh, wow. I didn't expect it to be that long in the US.
Well, it's not great here all the time.
No, that's for sure. That's for sure. But yeah, that was a good one. I guess I'll take my point and go into the next month.
Yes. Starting off the win. So maybe this is an indication for your year.
I hope so. I only hope so.
All right. Well, Omari got the win. So we'll be back next month to determine if I can be stumped in equity in action. It is also Black History Month, so big ups for that. And we will see you next month.
And for those who are not looking at this, my fist is up in support of Black History Month. Yes,
mine is
power,
too.
power.
And for anybody that hears a bark in the intermittent, I'm dog sitting. So normally it's Jace in the background, but we have extra dogs this time.
We'll take care of those dogs. Peace, everyone.
Bye, everyone.